Everyone from the East Coast, from the West Coast, and maybe from the rest of the world. Welcome today to our annual series on the topics of women's health. My name is Zeev Kain. I'm a Justice Professor at the University of California and the President of the American College of Perioperative Medicine. I'm your host for today. I'm the moderator. This webinar could not have been done without the generous support of Becerra and Exparel. It's a drug that does the right thing at the right time, and you may hear about it later on. And I want to tell you first the story of why did we even put this up together. Our society was formed about 5 years ago, and the idea behind the society was to break the silos and bring all the players into one space. And what we have started at the beginning is we really started with the orthopedic space. And we started with the orthopedic space because that's a space that was driven a lot by value-based care. And so people were more willing to work together, which was great. And we put up a number of meetings. Well, we're now moving into other spaces as well. And the first space we're moving into is women's health. And the choice of women's health was not accidental. The choice is very deliberate. It is a very hot topic right now in value-based care. It's a topic that is significantly underserved, and we definitely need to do a lot of work in that area, as witnessed by most recent statistics with COVID. So today, we are putting together an amazing webinar. And this webinar really focuses on 3 contemporary issues within the space of women's health. We're going to open with a talk from the front line of somebody who coped with COVID in a way that probably nobody else coped in the country, because now we know better how to cope with it than those days. We're then going to move into the area of enhanced recovery, which is even more important today than in usual other times because of COVID. And then we're going to move on from there to talk about value-based care and what's the impact of COVID on value-based care. So 3 amazing speakers. And in the spirit of break the silos, you have 2 anesthesiologists and 2 obstetricians. So nobody can blame anything on anyone. We're missing a nurse and we're missing an administrator, but I'll make sure we have them next time. With that in mind, we're going to move on to the first topic. Oh, before we do that, I was reminded to tell everyone that you have right now on the bottom of your screen a question answer button right there. You can see it right next to the record. So if you have any questions, please click on it. We will see your questions. The chat function is enabled, so you're not going to be able to use it, okay? So Q&A, any questions you have, just go to the Q&A, just click on it. And I can see that Matthew Becker has put in a nice thing at the bottom. You can see, just push the Q&A for everyone to ask any questions. Okay, with that, I'm going to continue. Our first speaker is Dr. Ruth Landau. Dr. Landau has a long and distinguished career on several continents, most recently the North American continent, and she may tell us about it later on. She's presently the chief of OB anesthesia at Columbia Presbyterian Health System, although she'll tell you I think it's Columbia, New York Health System, and maybe you'll explain that one to us. She's also the president-elect of SOAP, which is obviously the Society of Obstetric and Perinatology Anesthesiologists. So Ruth was in the delivery rooms when COVID hit, and she had to deal with all the issues that we in California are just starting to deal with. And I've asked her today to tell us how did she deal with these early days of COVID in New York. So with that, I'm going to turn it to you, Ruthie, and please take over.
So thank you very much for the invitation and the opportunity to share with you. It feels almost easier now. It's been a couple of months, and we're sort of in a recovery phase right now. So I need to do one more thing here. Can you see my screen? Yes. So just to answer a few questions that had to do with where I work. So New York Presbyterian is a consortium of 7 hospitals. Columbia University actually oversees the medical care of 2 of the 7 NYP, and I'll actually be talking about it on my slides. So let me share with you what my plan is for this conversation. I really see that as a chat. It's not a lecture. So I want to tell you a little bit about the numbers of COVID-19 in New York City, the logistics as they hit us when we started seeing our first patients, then obviously more focused on what happened on the OB anesthesia side, and the difficult sort of interaction between the patient care and the experience that we value so dearly as obstetric anesthesiologists, and how to maintain patient safety and also at the same time ensure our safety and that of our of all the healthcare providers and our families as we're caring for all these patients that turned out to be COVID positive. And I wanted to specifically talk about how we dealt with that as healthcare providers and share with you a few lessons. So the data in New York looked like that, and there was this New York City government website, which I never had checked before in my life, which became my best friend. Every day I would go and look at the numbers, and a lot of data was there. And I think this is also something that I've never had to deal with before, is sort of look in the news, look for policies that were actually released by governmental authorities. I always thought that as an MD, I can practice as I see fit to be for the best of care of patients. But here we really had to follow policies and governmental issues. So this is the map, and I'm showing the map not just to show you the case rate, which is depicted here, but I put push pins to show you where two of the hospitals that Columbia covers. So the bigger push pin is our academic center. The smaller one is showing where our satellite community hospital is. And as you can see on this map, it's not so much for the numbers, but just to show you the heat map by zip code of residence, the number of patients who are COVID positive. We're very close to where the heat map is with hotspots of COVID-19. Another way to depict that is the percentage of positive patients. And again, don't pay attention to the numbers per se, but in some areas there were up to 25% of patients who were COVID positive at any given time point since March. And that's the same website shows us these graphs. We're now in July, obviously, but as we were seeing the ramp up of cases, that's exactly what we saw in our labor room, which was we were hearing about the cases early March, and then suddenly patients started to appear. So these are the cases, these are the hospitalized patients, and unfortunately the deaths. And right now we're in a very good place where we still have a few cases, but obviously not what we had in March. So it was, you know, as I was living things in the labor room, I would grab the New York Times and actually see what I had lived that day in the labor room. This caption here, the patients were delivered. No one realized the mothers had the virus. That's exactly what we saw. And this is what I call our index case, which I'll talk to you about on my next slide. But we had this, and this is the entrance to our children's hospital. It's exactly what it looked like at the time. We had that. Some pregnant women in New York City will have to deliver babies alone. And this was obviously devastating. But as I mentioned before, we had to make decisions to ensure our patient safety, healthcare provider safety. And so for a very short period of time, we actually didn't allow visitors. And then that decision was reversed because Governor Cuomo in New York felt that we should allow women to have their partners, and we had to follow the policies. We had to ensure that everyone followed them. So in addition to providing care in a situation that was new to all of us, we also had to pay attention to all that. And then for just a short week, we didn't allow the partners, and then we allowed them in the hospital because it was felt that it was the better way for these women. So talking about general logistics, I think at the same time as we had all this happen, we obviously had to ramp up. And one of the most critical things, pun intended, was the ICU surge. So it became obvious that elective cases need to be canceled. We had to consolidate outpatient practices. And so what my colleagues from the critical care world did is absolutely remarkable. And it happened, I can say, almost within 48 to 72 hours, which was to create what is now famous as the ORICU. So these were main operating rooms that were called the pods, where 4 ventilated patients were admitted under a new model of care. It's the supervised pyramid staffing model, which I'll show you in the next slide, with EICU consultation. This was published in the New England Journal as a really innovative model of care that I know has been then deployed in other healthcare institutions. So what that required was the redeployment of healthcare providers with just-in-time training, which was everything. As I said, felt like it was improvised, but required a lot of coordination with new roles, new roles for providers who had never done that before. So I just put here a few of them, but it's not exclusive or exhaustive. There were proning teams, e-palliative care consultations, and some of our colleagues who became family liaisons. So our colleagues that either didn't or couldn't for their own healthcare reasons provide care in the ORICU actually stayed at home but were providing e-consultations with either the palliative care teams or the families themselves. So this was in the main OR. We also had our intubation squads, or the COVID squads as we call them, where teams were dedicated to go and intubate everywhere in the hospital or wherever needed. So the OB anesthesia team was actually not involved in that because we had enough in our own division and on our plates. So we were not redeployed. We were actually covering the main campus with our own labor and delivery room. And we actually, for a period of time, consolidated our 2 labor and delivery units, not because we wanted to close the other delivery units in the satellite hospital, but because they needed that space, particularly the postpartum unit space for the medical ICU surge. And all this overnight, we had to merge our 2 labor rooms to allow the medical ICU to utilize our satellite hospital LND. And at the same time, it became obvious that none of our sicker women would be able to be admitted in the ICU or the ORICU because they were over capacity. So we created, over a period of 72 hours, an OBICU in our own LND. So I'll let you imagine, if you're an administrator or used to these kinds of things, the number of phone calls, the number of communication and Zoom calls we had to do all of that. A lot of people ask me about how we did the OBICU, so I'm just going to put it out there. So the ORICU model, which is shown here on the left-hand side, was what our critical care colleagues and the intensive care and anesthesia team put together, which is that pyramid. And using this pyramid, we created something that doesn't exist yet in the US, and we are publishing it. The paper was actually accepted for publication if you're interested. We called it the OBICU, with 2 different pyramids. One, which is what happens to the patients who are sick with COVID or other diseases as well, by the way, because we figured that a patient might not be sick with COVID, but maybe just sick, required ICU level of care, and there wouldn't be any bed for her to be transferred to our main ICU. So we designed these 2 different pyramids, one which is what happens to the patient if she's still pregnant, and we sort of have a shared custody, if you want, between the maternal fetal medicine attending and the OB anesthesia attending at the top of the pyramid. We didn't put the ICU oversight at the top, 1, because they're not physically there, 2, because we didn't think that we would always need them, and because it felt like there would be more on a sideways sort of lateral track for us. And the second one is what happens to the patient when they're sick postpartum. So there we felt that the MFM involvement wasn't as critical because the baby is already delivered. And so we transformed our high-risk bed unit into 6-bed of OB-ICU. So this is what our main hospital looks like. It's a very large campus, as you can see. As I mentioned already, we overlook 2 campuses with 7,000 deliveries. At one period of time, we were actually merged. We have a high labor analgesia rate, an average cesarean delivery rate. And I just put here as a few bullets what happened to us. So our first case of known COVID patient was a patient who had showed up actually at our satellite hospital with symptoms of COVID. She had her PCR tested and she was positive on March 13. The reality is that she wasn't delivered then. She actually delivered probably 6 or 8 weeks later, but she was on our radar as the first patient. That's when we actually were aware of a pregnant woman that would deliver in our unit, and she was COVID. But the reality was different, and we really didn't know what to expect, and it didn't follow what my expectations. I thought the first patient would be someone who would have, critically ill with COVID, couldn't breathe, that we would rush to the OR for a delivery, and that was what we were preparing for. But that was not the case. Our first case was a patient who delivered on March 19, but the reality is that we didn't know she was COVID positive because she was asymptomatic, and that became a recurrent theme. Our patients were not known to be COVID positive, and if that resonates with you, that's what I was showing as the New York Times article. That's what struck us, and that was what surprised us the most. The sickest case we had was on April 8th. The total cases we've delivered, probably over 200 by now. We only had 8 patients who were admitted to the ICU. None of them actually required an intubation, and we're thankful to have not had any maternal deaths. So that's a quick summary. So I call it our index case. Actually, I was the one who placed her epidural that night, and I didn't know she was COVID positive. She was admitted very sort of nothing to signal anything, no fever. She was in spontaneous labor, multi-patient. She had her epidural at 2 o'clock in the morning, and she actually was brought to the operating room almost 12 hours later in the setting of chorioamnionitis. Nothing to write home about. They used the epidural that had been placed, but she started to bleed in the operating room. And so the gyn-onc team was called for possible cesarean hysterectomy. And the team, my colleagues, the anesthesiologists, decided to intubate more because they thought the bleeding wasn't controlled and sort of as a preventative measure, not because she had any symptoms. But after the intubation, they noted that she was difficult to ventilate, she was desaturating, she had a bronchospasm that wasn't explainable. And someone put it out there, maybe she's COVID positive, so they sent a nasal swab. By 6 p.m., she was actually stable. She was transferred, still intubated to the ICU because of the hemorrhage, but not because of oxygenation issues. And guess what? 2 hours later, the test comes back. She's COVID positive. And in reviewing the case, I put here, there were 6 anesthesiologists exposed during intubation, during the transfer to the ICU. Myself during the placement of the CSC, but that's a low risk exposure. There were the obstetricians, the MFMs, the surgeons, the pediatrician, the nurses, and our anesthesia machine, which we considered as being kaput for a while because we hadn't placed the filters that we found out later were necessary to protect the machine from being exposed. So quite the adventure there for something that could have been prevented had we known about all this. So the decision by our obstetricians and the hospital and Mary Dalton, for those who know her, was that as of the next day, universal testing for everyone. We cannot rely on symptoms. We cannot make decisions based on symptoms in pregnancy because the symptoms are not the same or just confounded by symptoms of pregnancy. This paper was published 2 weeks later in the New England Journal. A lot of people saw it. This showed that over a 2 weeks period of time where 215 women were tested, 33 out of the 215 were COVID-19 positive. So a high proportion of women who are positive. But the stronger message was that only 12 had fever or symptoms on admission. And so we couldn't rely on the symptoms. And that 3 of the patients developed fever before postpartum discharge, but it wasn't known at the time of delivery. I think this paper, and the obstetricians here can tell me, actually changed the way we practice were practiced in general in labor rooms because we saw that we couldn't rely on symptoms. So at the same time as we were caring for patients, SOAP provided recommendations. And I think the 2 major recommendations are that we absolutely need to optimize the safety and the mother's experience while at the same time we're preventing hospital-acquired COVID-19. So we need to minimize unnecessary encounters with patients. We need to avoid contamination of equipment and supplies, and we need to promote judicious use of PPE as it was at the time, or at least at the beginning, quite scarce even at Columbia. So I put here pictures just to show you what our labor room started to look like. It looked like, I hate to use the word, but a war zone. We had carts everywhere. We removed things from the labor rooms to put them outside to avoid contamination. We also tried to avoid as much as possible, or definitely placed out there the recommendation to avoid general anesthesia whenever possible. So we recommended providing early neuraxial labor analgesia, maximizes the chances that the epidural would work, and ensure optimal communication so that we could avoid the stat C-section where everybody runs in a room and increases the chances of contamination for everyone. So in summary, the recommendations are actually pretty simple, but they're pretty drastic in the way we practice. That's not how we practiced at the time, and it really is a culture change. So I'm just showing here, this is in a paper, a review article that we were asked to write immediately, was published in Anesthesia and Analgesia. I'm sure you know what operating rooms usually look like. They're not covered with plastic. We don't use buckets. We don't have things thrown in a bucket. But all this was to allow not to have, you know, open and close drawers, pull out things, pull out and put things back that might have been contaminated. I must tell you, not fun to work in these in these conditions. This is my colleague. The first night we had a C-section, the same night that we had that epidural that turned out to be on a patient, wondering, what do I do first? How do I do this? And the patient with her mask, with her better half on FaceTime with the phone. So we reached out to the community. As I mentioned before, SOAP created a toolkit, which is still available and still utilized worldwide. We communicated with SMFM, the Society of Maternal-Fetal Medicine, to have joint recommendations, which are updated regularly. They're here on the right-hand side. What SOAP also did was to create a COVID registry, which is up and running. We have 17 centers that are enrolling patients all the time. We have over 500 women with controls, and the paper that is describing those 500 first patients is actually being processed right now. I want to talk about the heroes. They've been talked about a lot, the healthcare providers. I know you'll recognize here Kubler-Ross curve. I think it followed exactly that. I just put here the timeline between February and now. We were all in denial initially. It's only in Wuhan. I haven't been there. I won't be sick. Our patients won't be sick. We realized early on that it wasn't the case. We were angry, frustrated. We don't have PPE. The policies change all the time. Life is awful. We were all depressed because our lives were different. Our patients weren't necessarily doing well, until we realized that with tactics, we actually can do better, that the new norm is not that bad. And I want to say that some of the new norm is actually really good. So the OBICU is something I'd been dreaming of doing for a long time. I could have never done it before COVID, and I could have never done it in 72 hours without COVID. And OBICU still exists and will keep it beyond COVID. So some things are actually opportunities to be seized. We did a study which I called my residents' wellness study. Our residents were really put in the ORICU, in the intubation squad, and they were depressed and thinking, we'll get sick, we'll die, this is awful. So I said, let's try and see whether you guys are actually protected by antibodies that you might have developed. So we ran a survey over a week of time. It's around April 20th, so it's 7 to 8 weeks into the outbreak. We looked at their demographics, community exposure, work-related exposure, and whether they became symptomatic. And we also, I purchased online the first Chinese kit of antibody testing that I thought had the best specificity and sensitivity. The results were not at all what we expected. First of all, 58% of the team said that they felt they had a work-related exposure, of which half said it was high risk. In other words, I intubated a patient without PPE, and I think the patient was COVID positive. Only 26% of the 58% had post-exposure symptoms. And the antibody rate is really low. It's 12%. At the time, everybody was telling me the kits I bought sucked, if I may say it this way. The reality is that we know now that we don't develop antibodies that easily. The results are that the one single most predictive factor for having antibodies was whether you came to work or commuted by subway. So I think what we found out is that probably our PPE was protecting us better than we thought, or that we just didn't get sick. And the reality is that it was actually a good message to share with the team, to say that we didn't get that sick. If we got sick, maybe we got antibodies, and everybody's doing actually pretty well. So the lessons are that communication is key, that the drastic and rapid change in workflow requires really communication and resilience. We had to ensure that we had PPE. Actually, we were lucky we did have it, that our policies constantly evolved. I didn't talk about it, but some of them have to do with moms, but a lot of them have to do with how to protect the baby. We know now that transplacental transfer is a thing, so it's important. We know that on LND, 85% of women are asymptomatic yet COVID positive. Only 10% got mildly symptomatic, and only 5% got critically ill, which is relatively good news. Our maternal outcomes were good, and that despite perceived work-related exposures, few became sick and even fewer developed antibodies. So thank you, and I know that I'll be asked to take questions at the end. I look forward. Thank you.
Wonderful. Thank you, Ruthie. You mentioned that you had the opportunity to implement some changes you really wanted to do, but you couldn't before. And it reminded me a lot of the work of James Cotter. And for those of you who don't know, he's a Harvard guru in change management from their School of Business. And he has a change management process of 8 stages. And I got exposed to his teachings when I was the chair of the Department of Anesthesiology here and later the Dean of Clinical Operations. We bought a book for everybody that's called My Iceberg is Melting. It's a great book. It's 30 pages and it talks about how do you cope with change. And the first step in coping with change is a burning platform. Something urgent that causes you to take a change. And obviously you had it. We all have it. And so I'm going to basically say to everybody, I think this is a great opportunity to also do some changes in our systems. If we really wanted to do it and we couldn't do it, well, maybe now we can do it. There are multiple examples for that are not within the scope of this conference, such as telemedicine. But anyway, I was very impressed by what you presented. So thank you so much. We're now moving to the next speaker. And the next speaker is Dr. Elizabeth Cherot. And I know Elizabeth since she was a speaker at our annual meeting on enhanced recovery during the OVBC meeting. The response for her was amazing. So I said, okay, I have to bring her back. Dr. Cherot is an obstetrician and the chief medical officer of Axia Women's Health. She has been active in the area for more than 20 years, and she's one of the pioneers of enhanced recovery, generally speaking, and as within the space of women's health, she is it really. And so what I asked her is to talk specifically about enhanced recovery, which we all know how important it is, within the context of COVID, and tell me how did that change and what the opportunities are. Elizabeth?
Hi. So I'm hoping my screen, well, I know I'm off mute. Let's start with that. And then hope that I get to my slideshow. And try and do this from the beginning, which always helps. So let me start with thank you. That's a very nice introduction. I appreciate it. And I absolutely enjoyed the last conference we did together. So thanks for inviting me again. And Ruthie, I was across the river with Axia Women's Health, which is in 5 states, one of them being New Jersey, Pennsylvania, Indiana, Ohio, and Kentucky. So as the wave of COVID was hitting you, we were watching with bated breath, no pun intended about the respiratory issue there, but as an OBGYN who's practiced for 20 years, we're taking all the lessons we could from all of you. And we did see a lot of New York City patients coming across the river in our North Jersey practices. So anyway, I would just want to say thank you for getting some of the publications out because it was extremely helpful. And as you quoted that New Jersey article, or excuse me, New England Journal of Medicine article, that really influenced us tremendously and changed lots of what we do. So today, this is a massive talk to do in a short amount of time. So I just want to make sure everybody understands that I'm a consultant for Procera, and you'll probably see it as I go through. And I'm going to go right to why enhanced recovery is so important in the setting of COVID. We started our pilot way back in 2016. We're now in 4 hospitals in 2 different states and plowing to kind of make this the priority in the other hospitals that we're in across our 5 states because we've reduced our length of stay in our very first hospital from 3.7 days down to 2. We had great patient satisfaction, felt like we were increasing patient communication and honestly engagement. We did a standardized protocol, which we'll get to, and I'm sure Dr. Lagrew is going to talk about how great that is for value-based programs. And the ultimate thing was actually reducing the narcotic use. So with that, I'm going to get to what is enhanced recovery. I'm hoping most of the audience knows that it's a program that was really pioneered in the colorectal space and urogynecology and other spaces, taking the patient from the home through surgery and then back home again. It was really started in the national health system over in England. This paper that came out, I guess this is like 2014. So it seems like we were way behind. We're actually discharging patients on day one, believe it or not, from C-sections. And a gentleman named Ian Wrench, who I've actually gotten to know quite nicely from Sheffield, England, who's actually anesthesia. So our program, we decided we better check with CMS to make sure if we were discharging people early, was that going to be a problem? The answer to that is no. ACOG, they were not telling us we needed to send patients home, that it was, on what day. It was really, obviously, it's really our payers that are telling us that. But from a clinical position, if we could get them home early, we were allowed to do so. So realize that I think the idea of Cotter's book is actually really timely, because for us, it was a big change. And what we really wanted to do was standardize a program with really good outcomes, improve our patient engagement. And also it took a huge team. And I talk about this usually in my longer discussion about ERAS, about who needs to be involved. And I'll tell you, the worst was doing grand rounds with the pediatricians, trying to explain to them why we were doing this and that we weren't trying to drop kick patients out. So back in 2016, we started our pilot with 100 elective repeat sections, moved on to all elective low-risk patients, and now it is now the standard for all of our C-sections in our hospital. And so by the time we got to this third year, the pandemic hit. And when we looked at guidelines, there weren't any at the time in the United States. This came out by ACOG in 2018, and it was really about GYN surgeries and not obstetrics. So we kind of realized we were one of the first to do that. Guidelines came out, I don't know, about 2 years into all of this. And so if people don't have this paper who are obstetricians, this is in the American Journal of OBGYN. It is really helpful to look at for guidelines. We did something unique, and something that for COVID, which was super important, is that we engaged patients at 28 weeks to understand the process. We did do it through telemedicine, so that we would have somebody educate about what would be happening during their C-section, when we would get them scheduled, the process of getting COVID tested, which we're now as a standard across our hospitals, which we really learned from Ruth's hospitals to do that. And we actually gave patients an app. So we, if you told me 4 years ago that I was going to actually build an app, I would laugh you, kind of out of the room, because I don't even know how to use my DVR. I laugh, I now have an Apple Watch, but that was many years later. So we built an app to engage patients, to give them all that information, which in the setting of COVID was really important. We could drive what the changes were through our app and actually drive patient information to them who were asking questions about, am I going to be separated from my baby? Am I going to be tested? Is there a COVID unit on our floor? A lot of the questions that Ruthie kind of went through that, she went through live that we learned from. And one of the part of this that we used this for was not only compliance, but be able to actually track patient outcomes and follow them post-operatively. And I'll get into that a little bit. This is what it looks like. So my nurses will actually log in and see how the patient is doing. We can actually, avoid some patient phone calls to the office, but more importantly is in the post-op period, is avoiding coming into the office and having more exposure, or coming into the ER. So we track everything from breastfeeding, mood, pain control, moving around, questions about DVT. All of this are in this app that we're driving. Realize that the National Health System uses a midwife and does home visits. And I knew I wasn't going to be able to get my payers to pay for that. So we found a digital way to drive this. We actually and I could get into all the evidence about this, but we start people on a carbohydrate load the night before. They're diabetic, we actually hold it. We also give them Pepsid. And patients get information about, again, their COVID testing, which has to be done. We do the standard, I don't do this. This is my anesthesia who's doing, the standard regional anesthesia, and we're really looking for multimodal pain relief, and going to get into that a little bit. We do temperature, really trying to do a warmer around patients, and even in the setting of COVID did this as well. Again, the whole OR is draped, which is kind of amazing, and we're in full PPE for our C-sections. I'm not sure, we had masks, gowns, shields. I mean, it was overwhelming, and we were starving for it in the beginning as well. And of course, the mask policy at the time was we weren't needing to wear masks in public. So it was really kind of trying to understand how we had to get so dressed up for all of this. We did a standard nausea and vomiting program. I've been having lots of questions about this, and I presented this in the past about Zofran, Reglan, and dexamethasone seemed rather aggressive, but we try and feed people right in the recovery room. And we actually, during the surgery, inject in the incision long-acting liposomal bupivacaine. It takes maybe 2 more minutes to the whole procedure, which for a repeat scheduled C-section, most of the time is an uneventful event, thank goodness. And I'll get into a little bit the data on the opioids. But again, and I actually think this comes from SOAP, Ruthie. Your prior president helped me with some of these, just about how important the multimodal analgesia, and the evidence is super high for that, as well as early nutrition. For us, we not only did the carbohydrate load before, which had some change management with anesthesia, but afterwards being able to have patients eat. And frankly, wanted to get them out of the recovery room as fast as possible for less exposure during COVID, and then move them as fast as possible too. So our post-op day 1 management was standardized to, we gave Ofirmev and then standardized Tylenol and Toradol around the clock. So it wasn't on demand, right? It was just a continuous, every 3 hours you were getting a pain medication, and we were switching to oral right away for the Tylenol and Motrin on day 2. And we've changed our protocol over time, Ofirmev being rather expensive, and then also just switching it right to Tylenol as soon as people could actually tolerate food. Mobilization being really important as well. Again, this is more, and also just about getting patients, out the door and impacting both their mood and their depression. And again, got rid of their catheters early, and I'm flying through a lot of information and realized, well, this will be available. But we did track their mobilization. Things that changed with COVID is, we used to say walk, so many steps down the hallway, and they could actually track on their app how far they went and input that. We had to have patients really stay within their rooms. And just as, having a partner was not allowed to leave the room if they stayed with a patient for 24 hours. So our hospitals allowed them to stay. Like I said, we did get all those New York patients for a little while. But we did track that, and we had them doing laps in their rooms, which sounds kind of funny, but we had them masked at all times. So if they left the room for any reason, we also, again, used this to really make sure we could follow patients afterwards, so they understood what was expected of them, both prior to surgery, during, and after. And I want to talk a little bit about readmissions. When you're sending somebody home on day 2 or even day 1 from surgery, you want to make sure they don't come back. And for our sample, and that's a measurement that people look at us for. This is actually what, right through our app, we could actually track patients in their process and where they were and how they were answering the questions we were pushing to them. We had a patient actually describe her drainage from her incision and felt like, she was a patient we needed to bring in early to get treated. So we did that. And actually did this all through the app, and this avoided an office visit. And at the time got her treated, and something we continue to do during COVID to use this technology. We had great engagement with the application. We've also, we have decreased phone, but more importantly, we had 12.3% reported it prevented a visit to the office and to the hospital. So for us, this was a great tool to use for surgery post-operatively. And obviously we've relied on it more and more with our telemedicine. Catheters, we got out right away. Within our three hospitals in New Jersey, one of them removes the catheter within 12 hours, another removes in the recovery room, and another removes at 16 hours. I'm not sure why. I don't know if that's just a nursing issue. But looking at, with our first 100 patients, we only had one patient that actually had urinary retention, which is an interesting point because hospitals measure that very differently. If you straight cath someone, that's not considered urinary retention. It really has to be in for 24 hours. The catheter itself, then it's considered prolonged. If you replace with a catheter, not just a straight cath, and that stays beyond the 24 hours, that's actually an issue. So I'm going to talk about opioids because this is actually when I first started this back in 2016, 2017. This is when the opioid crisis was really being discussed among obstetricians. I knew this was going to reduce opioids, but I had no idea the impact. So these are milliequivalents of morphine. So I went from writing prescriptions, ridiculous amount, to writing none. And what we did with just switching from a no ERAS program to ERAS for all of our sections, we then added the Exparel, and now we would show patients that they didn't need an opioid to go home with. So I don't think I've written an opioid prescription in months, if not, probably almost a full year. And these are all the data that's come out about using a shared decision-making. And once you show a patient that they've only taken 2 narcotics or maybe only 1 in the last 24 hours, that they don't need to go home with that. Really important, and we do plug that all into our app and give the information to the patients about it way ahead of time. So a couple things about patient satisfaction. We've had, if you have an application, you're able to drive some of those surveys and really follow patients. And we've had great responses from patients. And we actually, had an increase in our Press-Ganey scores, which everyone talks about. But we ask questions through our app to drive those and do familiar questions that they may get on that Press-Ganey. And then our length of stay, which was, in the setting of COVID, this is it. If I have to send a patient home, ideally I'm getting them home in day 1 or day 2, and I want them comfortable. And I want the nursing staff to be involved, the pediatricians to be on board, and that absolutely accelerated all this. I joke about the grand rounds I gave to pediatricians, and if I look back to 2017, I'm begging these people to realize that I'm not dumping patients out of the hospital, and now I'm getting comments from the pediatricians saying, thank goodness we had this all in play. So patients are feeling more comfortable, able to breastfeed because they're in better control, their moods are better, and are able to take care of their loved ones, their other children. So just quickly to make a big plug to get this done is that, and I have several slides on the financial impact of this, that I got a nice paperweight from my hospital for doing this back in 2017 by saving the hospital a ton of money. But really, starting a program like this doesn't take much. It does take a lot of change, and it takes a lot of people to make this happen. Quite a big multidisciplinary team, but the return on investment was huge the first year and even bigger over the time. So I'm back to the original, and I probably flew through more than I needed to, but I wanted to make sure that I covered the most important parts, which is really that the length of stay in the setting of COVID, you need to make sure your patients are comfortable, that they understand what the expectation is, and that you're really able to follow them once they're home. ACOG talks about their 4th trimester, which mathematically makes no sense to me whatsoever, that they call it that, but that you have to have some way of being able to do that to keep them satisfied and to keep communicating with them. So that was my fast and furious, and happy to answer questions over when this is finished. So I'll stop sharing my screen.
Thank you, Elizabeth. I just want to remind everybody that we are going to have a presentation available. It's being recorded, and we are going to send out the slides as PDF document to everybody who is listening in. So don't worry about the fast and furious. You'll get the slides, and then you can reach out to us with any questions. With that in mind, I'm switching to the 3rd speaker, and this is Dr. David Lagrew. And David is an obstetrician. He's an expert and a specialist in maternal fetal medicine. In addition to that, he's now the Executive Medical Director of Women's and Children's Services at Providence St. Joseph in Southern California. I'm sure you know that Providence is this small, tiny system in Northern California. And he's also a member of the Executive Committee of the California Maternal Quality Care Collaborative. And I asked David to talk about how does COVID impact value-based care? And value-based care is a complicated issue, but I'm sure David is going to make it justice and kind of just encapsulate it and tell us what's the important part in these particular days of COVID. So with that in mind, David, please.
Yeah, so no pressure there, huh? Let's see if I can get this going. There we go. Good. Well, thank you, and I'll try to address that in the time we have. First, let me start by looking at the question that we've learned. What are some of the nuances of value-based care in obstetrics? Well, the good news is we have well-established metrics now for assessing quality for both the mom and the baby, and so that's helpful. As well as we're somewhat used to bundling our care for obstetrics in the sense that the total OB reimbursement system is just that. But there are some challenges. Unlike orthopedics that was mentioned earlier, we don't have any expensive devices or medications. And what that means is that really when you delve into cost in our care, it's all about people cost. Our internal, and I would argue some of the analysis I've seen externally suggests that it cost us around $100 an hour in the intrapartum site, and postpartum is just under $25 an hour. So there's a differential in where you are. Obviously, the other nuances are adding in the OR cost and recovery cost if you have to do a C-section, et cetera. So David, how does this apply? Yes.
Yeah, I'm sorry to cut in, but you're not sharing your screen right now. And I don't know if that's intentional or not.
You know, I thought I was, so I will try that again. How's that look?
Now it's excellent. There you go.
I absolutely apologize.
No problem.
I couldn't see it from this end. So hopefully that's the full screen.
It is the full screen.
Good. Okay. Thanks for interrupting. So now how do we compare this to what we were trying to do with our COVID-19 response? And let me share our thanks as well to the folks in New York who preceded their surge preceded what we're seeing on the West Coast. So we had a bit more time to prepare, but we really had three major goals. One, how could we reduce the viral transmission to both to everyone, the patient, the family, the caregiver? Number two, how could we conserve our resources such as PPE, blood, bed space, et cetera, so we could not only have room for our own patients, but as well as was mentioned earlier, help out the rest of the hospital. And then how do you minimize the strain on physicians, nurses, midwives, other caregivers who at the same time are not only worried about their own well-being, but the well-being of their loved ones as well. So our strategies were as follow in labor and delivery. First of all, we changed and recommended not ever admitting anybody unless they were absolutely in active labor and defined that at 4 centimeters. Now, obviously, if they had a medical reason or their question, the mom or the baby, we would admit before that. But otherwise, we cut out all the so-called soft admissions. Number two, we did not allow elective induction of labor before 40 3/7 weeks. I know that's a hot topic in the OB world, and we can perhaps talk about that. And when we did it, we recommended outpatient cervical ripening. So we didn't put the mother in a bed overnight getting misoprostol or having a balloon in. We performed balloons as an outpatient. Elective surgeries, elective cesarean sections, we couldn't eliminate them completely, but we did increase our counseling and we had a specific patient consent, and that reduced some of the cesarean and long stays. And we routinely sent moms home after vaginal delivery after 1 day and C-sections at 2 days. Well, what were our quality results? Well, as you could see from that list, many of these have to do with strategies lowering the cesarean section rate. And the hospital I'm going to share with you, which right now is actually in one of our hotspot zones here within the region of Southern California, since a year to date, they have a NTSV C-section rate of 20. And they were able to lower it and keep it that way, as well as the rest of our region's done pretty well. The outpatient cervical ripening and later admissions reduced our staff exposure, and as well, I would say, improved patient satisfaction from that. We lessened the likelihood of the full and overburdened labor and delivery. And again, for those of you who practice OB, you realize the really bad things happen to patients when you have a full labor and delivery. Our severe maternal morbidity and unexpected newborn complication rates remain stable. So our changes in enforcement and things of that nature did not seem to make a difference in that. And as was mentioned, we really kept a lot of open beds that have now allowed us, as the surge has hit, to have plenty of room for everybody. This curve shows you the NTSV. Again, I'm going to show you from one of our hospitals. They do just under 5,000 deliveries a year. It's a private hospital. They do have a couple of MFM fellows there, but no resident deliveries. And you can see their C-section rate has bounced around through the years. But since we hit this crisis, they've really kept it down. This doesn't show their June data, which also was at 20% for an NTSV, with the national guideline, for those of you who don't know, being keep it below 23.9. Now, what were our outcomes as far as costs go? The other part of the equation for value-based care, well, we saw the admit to delivery time and the mother-baby stay both decrease. We reduced the C-section rate, and that meant when you add that into cost, that reduces our cost from OR and recovery. We reduced the amount of PPE because that really is a burn rate on how many beds are occupied per hour. And as I mentioned, our bed space was opened up. Here are length of stays for both vaginal and cesarean section. We have not, Dr. Cherot, gotten down to the 2 with the C-sections, but you can see these are all comers, and but you can see a very significant decrease over the past few months in the hospital statistics. And if you look at cost data, this is some of our preliminary work. Because we cut about 3 hours off on average in labor and delivery and about 7 hours off the mother-baby unit. This is saving somewhere by our estimates $400 to $500 per delivery. So I would summarize saying that clearly there can be increased costs because just as been described, we have started viral testing, and obviously the PPE cost and the staff time, the extra staff time it takes to care for a patient when you're constantly working under these conditions. But again, I think our strategy of using specific clinical recommendations allowed us to offset some of that cost and at the same time keep our quality metrics stable. So I think that meets the equation for value-based care in that if you reduce costs and you keep quality stable or increase it, then you have more value. So again, our reduced costs came from shortening the admission to delivery time, the overall length of stay, lowering the C-section rates, and again, in a pandemic situation or where we're, definitely in pressured as was put earlier, we think this was the right thing to do for our staff and our patients. So with that, like others, I would be happy to answer questions as well. And I'll stop sharing. Hopefully that worked.
It did work. Perfect, David. Thank you so much. So with that in mind, we are on time, I'm happy to say, a bit over, but not that bad. And we have an opportunity for questions. And I'm going to start with one question, which is quite interesting and kind of repeated itself, which is, I've heard about a number of improvements in your systems, right? From a number of you. And I wonder how much of this is sustainable and how much will you keep unrelated to COVID? And I'm going to start with David, because you're the last speaker. You talked a lot about changing your criteria now for admitting patients. Okay, yeah. Get it. Now that you see that the outcomes are better, are you going to keep it when COVID is done?
Yeah, and of course, what we're projecting here in California is, we're still in a hot zone situation, and so we really think we need to keep these guidelines going at least to the end of the year, and obviously we'll reassess them based on our prevalence and what we're seeing, but we'll maintain them. I think though, to hard bake them, to your point, what's going to make them long term is the satisfaction that patients and our staff. It's interesting, much of the hubbub over inductions and I want to do this and whatever. No one likes a 2 or 3 day induction. That's a total loser for everybody, right? Because if you're the patient, who said sucks? I guess we're okay to say that word. But as well for nursing and for doctors. And so I think what a lot of this has done is allowed us to test out things that, to your point, maybe would not have been tried had there not been this experience.
Got it. And Ruthie, let's move to you now. Was your lengths of stay different during the COVID? And by the way, will you now adopt it going forward?
So the length of stay was shortened for a variety of reasons. The obvious ones are those that people are thinking of. But if you remember, I told you we merged our two labor rooms. We were really short on beds. So the reality was that we had no choice, and we also didn't want to have patients mingle in rooms. And although the partners were allowed in the labor room, we didn't talk about all these things, but they were not allowed on the postpartum floor. So it was a combination of things. We had at least 5 good reasons to shorten the stay. Your question is on point. Is it going to stay? I think it will. We were a bit behind, I think, in our ERAS protocols and tended to keep patients. So again, superb opportunity to jump ahead. We were going to implement a shorter length of stays. Now it's in place overnight. I had a question actually to the obstetricians. We're all talking about shortening length of stay to 48 hours, maybe even lower. Is that the best practice to make it short? What's the judicious amount of time, and how do we make that sustainable? Because you asked me before, Zeev, I trained in Switzerland. I did have a C-section myself. I stayed for 6 days post-op even though I needed nothing. I was on 0 opioids, I can proudly say that, but I stayed for 6 days. I know since then they've shortened the length of stay, but what's the right amount? What's too short? What's right? What's too long? And not from a cost benefit perspective, from a patient outcome perspective.
I think that's a great question, Ruthie. I think from our standpoint, I mean, pre-COVID, we were doing a lot of ERAS. For us, there was even more adoption because it was mostly Axion that was, doing this protocol, and throughout the hospital had more adoption of it, obviously with COVID. For us, it's about, when is the patient ready? And is that patient ambulating? Is that patient, comfortable meeting the afebrile, the usual criteria that we all say, and so it's a mutual decision. We didn't kick anybody out, and there are patients, out of the first, when we did about the first 280 some odd, looking at patients stayed because of their babies, not because they were uncomfortable or needed more pain medication. So if you met a certain requirement, or of being ambulatory and comfortable and were mentally ready to go, that's when I think the ideal is. But I don't think it's 4 days. And I do think the National Health System has an incredible program where they have a midwife, who does a home visit. We don't have that in this country, right? We don't have the doulas that are doing some of these things that, so again, that's why we use technology, because, we have that advantage. So I think it's an excellent question. Personally, I don't think it's day 4. I will tell you, I've sent a patient or 2 home on day 1. It was their choice, and I was unbelievably uncomfortable with that, and probably called them every 12 hours because I felt like, I was doing veterinary care, but it was their decision to go. So some of it is being prepared ahead of time of what their goal is, and making sure you're not drop kicking, making them feel like that by any means. So anyway.
Yeah, I would say in our experience, the bigger problem, it's less about the mom and more about, can you get all the normal newborn testing done so when you have hearing screening and heart, et cetera, that's an issue. And so again, that's a problem. But I think if you look at readmissions, most of them are actually for hypertension. Many you can't predict, and a few infections. And outside of that, that's why moms come back.
Yeah, I think
I'm going to make two quick comments. First, I'm going to draw parallels from the orthopedic world for you guys. The lengths of stay for hip surgery has decreased dramatically. And one of the reasons it decreased, and by the way, Kaiser has an amazing system for that, it's because they set up home ready for these patients. So now they start these patients with rehabilitation, and at home they actually have a meal service that comes home and physical therapy that comes home. And guess what? It's cheaper than keeping the patient in the hospital. So now drawing parallel, because I'm not an obstetrician or an OB anesthesiologist, but there must be some parallels where you guys can put systems in place, not unlike the UK, where people can actually be discharged the next day and somebody will go home to take care of them. And by the way, you can make sure ahead of time that the bathroom is next to where the bed is, for example, right? And so those basic things that are not expensive can save days of hospitalization. Does that make sense?
Absolutely. I think one of the things we've done since COVID is make sure our lactation consultants are available by telemedicine, right? So little things like, I'm sure you're doing the same, David. So yeah, I think it's looking at it holistically from the point optics of a patient, what they need to get home.
Right.
That may even be some help with the little ones at home, right? With that,
Now here is where economics comes into play. And that's not my point, but I want to put this one. The challenge is that the way you're getting paid, and David knows it best, is hospitals are getting paid separately than the community. And in the hospital, there is a DRG system and you get paid a fixed amount of money, period. So if the hospital now will put this in place, something for the community, the hospital is not going to get paid for it. That's it. So that's why only systems like Kaiser, to be honest with you, can now leverage and look at it the entire scope. And the hospital, it's important to them only if they can decrease the length of stay. And by the way, only if they're at 100% capacity, then they can say, hey, I release the bed now, bring somebody in. Yes, for that, I'm willing to say somebody at home. But if not the case, the hospital will not take care of patients at home.
Yeah.
And that's the downside of our current system.
Yeah.
And
Yeah, no, again, I'll go back to the newborn screening and testing. It's all about, because that becomes packaged into the hospitalization, you see. So you would have to get the payers to separate that out and pay somebody to do it at home. But obviously, to your point, it's doable. It's not high-tech stuff. It's
Change
anyway.
It's the financial models, and that's why we started with orthopedics, because they were the first to understand it.
Right.
Ruthie, I want to mention something. You mentioned cost benefit, and a lot of people think about cost benefit as the same as value-based care. And so I know you're not, but I want to clarify to the entire audience here. Value equals outcomes divided by cost, and value is to the patient. It's not to the hospital. The value to the patient is equal to outcomes. The outcomes are not only clinical outcomes. In fact, in outcomes, you have patient experience and patient safety and patient satisfaction. So when you discharge a patient earlier, it will qualify as a good maneuver only if your patient experience scores and the patient experience will not drop down, and the clinical outcomes will not be worse. The fact that the cost to the hospital has dropped is not in the equation, because it's the cost to the patient here. So my approach is, for you guys, what you're doing is, I think it's good because the clinical outcomes will probably not changed, and your patient experience hopefully did not change. And so it's a good value-based, a good value-based program. So I'm going to continue with that to the next question, and we do have a few more minutes. There was a question here about basically healthcare disparities. And I want the reaction of the three of you, because you're from very different populations. Do you see a different proportion in your parturients populations between, let's say, white non-Latinos, white Latinos, and African-American or Blacks? Any changes there, guys? Ruth, we'll start with you.
So are you asking about whether COVID seemed to impact preferentially? Absolutely, but there are a few reasons for, in our institution in particular, we know that any woman that was able to leave New York City left New York City. So we had a very different case mix during the initial weeks. That was one parameter, obviously. The second one, and some of it we published, our obstetrician published, there's another one of our papers that is coming out, which was that the crowding, I mean, the number of people living in the same apartment, actually the building itself is a factor that has been shown to be associated with the likelihood of being infected with COVID. So the number of people in the household, the size of the building, and then the third parameter is the commute, which could be explained in different ways. We showed it in one of our papers that using the subway was a factor for infection amongst the healthcare workers, but we've seen it also in other studies where we looked at commuting between boroughs, which was associated with a higher likelihood. So people who were not able to stay at home or implement social distancing. So long answer to your question, yes, 3 times yes. We also saw that in the SOAP registry, that there's an overrepresentation of Hispanic and African-American women. Having said that, there's no difference in their outcomes, no difference in cesarean delivery rates, no difference in preeclampsia. So there are more of them, but the course of their pregnancy didn't seem to be different, and we're hoping that the care they received was equal. We're very aware of disparities in healthcare.
Good. David?
Yeah, same thing. Obviously getting down to maternal mortality rate, you couldn't because the numbers are so small. But clearly, our increased numbers are tainted towards Latinx, having by far and away making up the biggest number of patients. And I think it is some of the social determinants that Ruth mentioned.
Excellent. And Elizabeth, did you see the same thing?
I would add the same thing. We have about 100 patients collected data on, and I probably should be sharing with Ruthie we're in the ACOG database registry, but same idea. We're not having different outcomes, but finding that more COVID with our Hispanic population and African American.
Great. So I'm going to present the last question and point that was brought up, which is the point of dexamethasone and nausea and vomiting. Obviously, I think your practice may have been to decrease nausea and vomiting and throwing on everyone and disseminating the virus. How does that work in the setup of the literature that comes out now about treating these patients with high doses and so on?
Yeah, no, this was a good debate because, and Ruthie, you know, we as obstetricians, and I'm sure David was having the same thing or is having it now, is that do I give my betamethasone to or my steroid to, you know, help with premature birth, you know, if I don't know the COVID result yet, if that's not back, or, you know, if somebody is developing symptoms, and a lot of that data came out very early about, you know, it could worsen the path for these patients. So for us, it was a conversation of, we were testing, you know, on our labor and delivery, we did take the clue from New York City to test everyone before they came in. So we felt lucky enough to know that for our scheduled sections. And we really did want to lessen any kind of aerosol to anything. And so we stuck to our protocol. And if somebody was COVID positive, then dexamethasone was held. So sort of a double standard to a certain degree, but I'm not sure David shaking his head if he was doing the same thing, but then they did, because it was a matter of, you know, what is the benefit to be, you know, to mom, is it, you know, which one would be worse? So that long conversations with anesthesia, discussing this, but right. So, and everybody every anesthesia felt like it was different, and longer conversations. And it felt like everybody was calling from the night before, the team that was on, and what did you do? And trying to learn from everybody's either mistakes or, you know, what the plan would be. But we did hold it for anyone who we knew was COVID positive. But the initial was, and that's why I brought it up, is I knew it was going to become a question, but we did try and standardize it to try and, you know, decrease any kind of vomiting or aerosolization of anything.
Yeah, they knew we were doing the right thing for the mom, huh? Yeah, I think the big controversy in that is over the dosage and what's going to be the effect to the fetus, because Dex does get into the baby and it's much higher dosage than we use for lung maturation. And so again, we're just going to have to see. It's just one of those things. But I think most of I certainly believe this, and I think most MFMs really believe it's a good thing to do because of the non-OB data.
And Ruth, any final comments about this topic?
Actually, it's interesting because we followed the news and recommendations, and so initially we had the same thing about NSAIDs. The question wasn't asked, but if you remember the French recommendation that said that NSAIDs shouldn't be given to patients with symptoms compatible with COVID because it will make the COVID prognosis or the trajectory worse. It was very difficult to actually have patients get NSAIDs, which I believe are absolutely indispensable unless absolutely contraindicated. And I kept on saying, we don't want to trade one epidemic with another. We're going to revert back to relying on over-reliance on opioids. So we made it very clear, and I was like a hawk behind this, that everyone should get NSAIDs unless they were severely ill with COVID, which was by far not the majority of patients. And those who were severely ill usually had also some kidney issues. So it made it clear that it might not be a good idea to give the NSAID. So just after we had resolved that controversy that didn't last for very long, came up the thing with dexamethasone. We shouldn't be giving it. And then we heard we should be giving it. And then, you know, you're losing everyone's trust as to what it is that we're told to do. And people start questioning everything that we're doing. it was at the same time, you know, our patients were getting hydroxychloroquine and other things. So it was just a big mess of just, you know, stop telling us what to do, or let me just not listen to you for a week because you'll be saying the exact opposite next week. But the reality is that I think we withheld for longer the dexamethasone than we did for other things. And now we're back to usual. But it was interesting. I mean, as I said, I think the biggest thing was not so much whether we should be doing it or not, but people becoming less, a bit skeptical about anything we were saying or any evidence we would produce. In the case of dexamethasone, there was sort of an announcement of the study before we actually got to see the results of the study that were saying that people did better in the ICU when they had received dexamethasone. I was actually holding back on that because my belief was that while NSAIDs should be absolutely given, dexamethasone didn't seem that indispensable to me. So we kept the no dexamethasone regime for longer until we actually saw the results of the study. And that's why I was intrigued by how you had approached this.
You know, I'm going to say that we are all best if we treat it as a medical issue and not a political issue. And one of the most difficult parts for me is that I think that people change their practice based on politics. And I would like to think that none of us is doing it. But the reality is that there are some forces out there that are trying to do it. And so we just have to remember that we're physicians and we do the best we can for our patients based on the available data from a science community. And we'll just stop there. All righty. So I think we have reached the end of our time. We had some good questions. We have a few more that we just can't answer right now. For the audience, you will get the slides as a PDF format. You will get a recording of the presentation. We'll also post it. For the presenters, Ruth, David, and Elizabeth, thank you so much. You exceeded all my expectations. And I know it's late on the East Coast already, so thank you very much. And you all look beautiful, and just be safe. Thank you.
Thank
Bye.
you for the invitation.
Thank you. Bye-bye.
Great.